All right, so welcome everybody. It is Friday, October 18th. Welcome to the Florida EMS webinar, where we're very fortunate to have incredible folks joining us from across the country and even across the world. I reached out to Dr. Sperry, who you can see is from the Pittsburgh area. Go Pitt. I trained out in UTMC many years ago. He's a professor of surgery and critical care medicine. You probably know his name from many of the big trauma studies, such as PAMPer and CXA studies, etc. Henry and I reached out to him to talk about his recent publication. So, Dr. Sperry, thank you so much for joining us, and take it away.
Okay, appreciate the intro, and it's anything that's done out of here is with my partner, Dr. Frank Guyette, who's also an emergency medicine physician, and we do a lot of things together and do some cool stuff in the pre-hospital early ED phase of care for traumatic injury. So today we're going to talk about a recent paper that we had where we harmonized 3 different clinical trials. And we're going to look at early Glasgow Coma Scale score and the prediction of traumatic brain injury. Okay, I don't have any conflicts. This is polytrauma following injury. This is like the most complex. You know, there's hemorrhage, and then the severely injured polytrauma patient, you throw in a little TBI, and that even makes them sicker. And you don't know whether they have TBI or not, which is, you know, the question. You don't know they have TBI until you get the head CT in the ED phase. And does that matter? You know, that's controversial. You may know that they're hemorrhaging, but does it matter whether they have TBI or not? You know, we've changed our resuscitation and how we're, you know, in the hospital, proper trial, 1-to-1-to-1 or early whole blood resuscitation. And that's pretty good. But despite our changes, mortality remains high and extremely early. And when you think about, if you're going to, this is the mortality rates being really high in the first 1 or 2 hours. If you die from hemorrhage in the first 1 or 2 hours, that means you don't have a whole lot of, you're not going to be able to intervene in the emergency department. It might be in the pre-hospital setting where interventions may have their benefit. And it just highlights the pre-hospital environment closest to the time of injury. In general, we're treating strokes as early, close to the time of stroke, and myocardial infarctions, closest to the time of myocardial infarctions, trauma, closest to the time of injury. And then typically, trauma doesn't occur in the level 1 trauma center parking lot. It occurs somewhere else. And so we can intervene. Now, resuscitation has undergone significant development, whether it's pre-hospital plasma, whether it's pre-hospital TXA, whether it's pre-hospital whole blood, whether, you know, other studies more recent, patch trial, again, pre-hospital TXA, rock TXA. So we have evolved for relatively simple interventions that can be done in the pre-hospital setting. And the PAMPer, cool trial, rather fond of it, demonstrated a 10% mortality benefit, but, you know, it didn't help everybody, it didn't harm anybody, but it didn't help everybody. But who did it help? When we look at the subgroups, what was ultimately found when we looked at it was that plasma benefited those with traumatic brain injury, those polytrauma patients with hemorrhagic shock. That was the inclusion criteria that ultimately were found to have traumatic brain injury. If you didn't have brain injury, early plasma didn't cause any harm, but it didn't benefit. And so, you know, that's where the survival benefit was. So it would probably benefit us if we knew if someone had traumatic brain injury. So you could give plasma, you could give whole blood, and there's no harm signal, but who might it be benefiting the most to give the personalized pre-hospital resuscitation? That may be those that you could diagnose or know about traumatic brain injury. So why did we, additional evidence to suggest this when we looked at lipidomics, metabolomics, and proteomics in the PAMPer cohort, there was something very special in those most severely injured and those with traumatic brain injury. I don't know if you guys can see my arrow. I can never figure that out, whether you can see my arrow, but in the right lower quadrant, yep. This is where the survival was. This is it's called N2 in this paper, endotype 2, severely injured with shock, in the TBI cohort. And the other ones, if you didn't have TBI, there's no benefit. And if you didn't have TBI with shock, there was no benefit. And there was something special in the multi-omic analysis, something different about this endotype 2 with TBI, where plasma either the patient population was special and plasma benefited them, or plasma did some benefit, early plasma. So what we want to know is whether someone, or at least we may want to know with personalized pre-hospital care, whether you whether you have TBI or not, and whether you can figure that out in the pre-hospital setting. So what kind of tools do we have? Well, the topic of this is whether we can predict traumatic brain injury using pre-hospital GCS. How good is it? And that's what I guess I'm discussing and you picked up. And what did we do? We harmonized 3 trials that were run and initiated out of Pittsburgh: the PAMPer trial, 501 patients; the STAAMP trial, pre-hospital TXA, which was 904 or 5 patients; and the POWER trial, which was a feasibility phase 2 whole blood, pre-hospital whole blood trial that was run during COVID, and smaller. But we harmonized all these trials at Pittsburgh, run out of 1,490 patients, median injury severity score of 16, and wanted to characterize pre-hospital GCS. So we looked at pre-hospital GCS. We had one pre-hospital GCS variable. We didn't have repeated measures, but we took and we told our trial sites, to use the lowest, or the only one that was available. And we looked at our pre-hospital GCS distribution, and we stratified it by the presence of TBI or the presence of no TBI. And this is sort of interesting. Remember, these patients are enrolled in the hemorrhagic shock trial, so it's not all comers. They had to meet criteria, and they had to be hypotensive and tachycardic or have severe hypotension. And obviously, the patients with no TBI have a very strong GCS 15, 14, 12, and 13, and just a few GCSs of 3. And then in the TBI, it shifts a little bit. Obviously, there's less in those with documented CT scan proven in the hospital TBI. There's less GCS 15s, 14s, 13s, 12s, and a increase in those with a GCS of 3. We just found this interesting that it's either 3 or relatively normal, 12, 13, 14, or 15, or 3. That's where the distributions laid in our analysis. We characterized that. Again, we looked at the distribution of TBI stratified by, we looked at GCS 3, we looked at GCS 4 to 12, and we looked at GCS 13 to 15, and we showed, as one would expect, a 60% incidence of TBI with the GCS of 3, a 42% of TBI GCS 4 to 12, and 11% TBI in those 13 to 15. It's as expected. It decreased as the GCS improved, and it was only 60% in the GCS of 3. And so we knew that there was confounders, and so we looked at pre-hospital intubation. And as we know, we tell our pre-hospital providers, typically, if you get a GCS of 3, there's a good chance you have an endotracheal tube. We weren't able to tease out, maybe some of those where patients were intubated and then they had a GCS of 3. We couldn't exactly tell what came first, the intubation or the GCS of 3. But in general, 91% of patients with the GCS of 3 were intubated pre-hospital, and 59 with a GCS 4 to 12. And as we know, the GCS of 8 or less is typically the intubation trigger. And there are sometimes GCS 13 to 15, 8% ultimately. And this was based upon the GCS that we had. Maybe their neurostatus deteriorated and then they became less than 8, or maybe the pre-hospital EMS felt that there was an alternative reason. A lot of these patients were in air medical transport. Probably the vast majority, probably 80-90% were air medical. So not ground crews, but air medical. When we looked at patients with TBI and those without TBI, as one would expect, they were older, they were more commonly injured via a blunt mechanism rather than penetrating. They had patients with TBI had lower blood pressures, higher shock index, and lower GCS, as one would expect, and had higher injury severity scores significantly. And this corresponds to higher mortality at 24 hours and at 30 days. It became a little bit more interesting when we stratified those patients of note in the GCS3, when we did 3, 4 to 12, and 13 to 15. The patients in the GCS of 3, they were, because of their severity of illness in the GCS of 3, they didn't all have TBI. Only 60% of them, interestingly. There was no difference in the rate of pre-hospital intubation. So that's just something that probably because they were sick, their GCS could be driven by also their severity of shock and other things, not just the TBI. And there was no significant difference in their pre-hospital intubation rates. They were more likely to die at 30 days. And then when we broke into 4 to 12, the mortality was actually shifted to the 24-hour mortality. In hemorrhage, it's interesting. Hemorrhage, you die early within the first 24 hours. In TBI, you don't die in the first 24 hours. You're more likely to die at, later on in the 48-hour, 72-hour window. So we may be just seeing some differences in the mortality risk occurring over there as we broke it up. There was an overall low mortality in the GCS 13 to 15. Our 24-hour mortality, if you looked at those stratified by GCS 3, 4 to 12, or 13 to 15, as one would expect, GCS 3 has a significantly worse survival, higher mortality. The 4 to 12 and the 13 to 15 were pretty similar. And 24 hours with no TBI, it separates a little bit, but it's proportional. Mortality is proportional to GCS, irrespective of whether you have TBI or not in these Kaplan-Meier survival curves. 30-day mortality follows a similar. Again, TBI correlates not just necessarily as what we plan to what their mental status is and whether they have TBI or not, but maybe their overall injury burden, their shock burden, and their TBI burden. And so as you worsen your GCS, your mortality increases, irrespective of having TBI or no TBI. And the TBI has higher mortality overall, as you can see on these Kaplan-Meiers. The meat of the story, and I don't want to overgo my time, is that when we did rock curve, characteristic curve analysis of a GCS of 3, we looked at sensitivity, specificity. The positive predictive value, as I showed in that one figure, was only 60%. The negative predictive value was 81%, with an overall area of the curve of 0.69. So a GCS of 3, there are other confounders, one being pre-hospital intubation, one being shock, and one being injury severity score. We'll get into that a little better. We looked at GCS less than or equal to 8, which is the trigger for intubation. The specificity kicks up a little bit. Positive predictive value comes down, and the negative predictive value goes up. And so if you have not a GCS, you have a GCS 9 or higher, you have an 85% negative predictive value. You unlikely have documented traumatic brain injury. So very good negative predictive values in the 80%, but not positive predictive values. So GCS really is predicting a lot of things, not just the presence of TBI. As we all know, it is a marker of mental status, not necessarily TBI. So we broke this down a little bit, and this is a interesting slide, and I'm sorry for all the red, and I didn't want to animate it in case it gets animated, but we did multivariate logistic regression to see what were the independent predictors of a GCS of 3 or of a GCS 4 to 12. So the outcome is here, GCS 3, and we wanted to see what was driving it. We looked at the overall cohort. Obviously, one of the biggest predictors was being intubated, as I show you in the overall. This is TBI and no TBI, and those with TBI had a 2.6 higher grade, independent of other factors. we looked at shock index, and we looked at injury severity. And the big drivers that were statistically significant were TBI, which just makes sense, shock index high, and it was a twofold higher rate of having a GCS of 3 if your shock index was elevated, greater than 1, and being intubated. Intubated was the biggest dichotomous 27 odds ratio for predicting a GCS of 3. So then we split it up, and then we looked at in TBI or in no TBI. In the TBI cohort, shock and being intubated were the big drivers, if you had TBI. And if in the patients without TBI, the biggest risk factor, the sole independent risk factor, was being intubated. And you got intubated probably because you were in shock, or you were in, had severe injury of some concern, but it was the only independent factor. We also looked at it because of the intubation was involved in everything. We got rid of intubation and looked at our models over here on the right, and we did it independently in the overall cohort, excluding intubation, and found that overall TBI was a big driver, shock index, and injury severity. When we got without intubation, injury severity and shock index was a predictor of GCS of 3, and similarly, patients without TBI also being in shock and being severely injured were the biggest drivers. And these are things we know. It just hasn't been really shown with or without TBI. When you look at GCS 4 to 12, really everything changed. Intubation was the big confounder and driver in the overall cohort and in the no TBI cohort. And when you took out intubation, the only really driver was severe injury for having a GCS 4 to 12. Really, what does this show? It just shows that pre-hospital GCS is confounded. It's confounded by intubation, and it's confounded by, as we would expect, severity of injury and severity of shock. So, can we do better? And I don't want to get rid of what are all alternatives? We have a new GCS coming out, which includes a pupil score, which is, we have ultrasound, which is transcranial Doppler or optic nerve sheath. These are just in the literature. I don't think they've hit the pre-hospital phase of care yet, but the things that might be coming down the pipeline that might have better predicting capabilities than pre-hospital GCS. There's also near infrared spec and quantitative EEG, things that might need a lot of equipment on an ambulance or in a helicopter that might not be feasible, but these are probably future things where we may go. Maybe there's a simple one. The military may be interested in analyzing some of these to assess whether someone has definitive TBI or not. In summary, pre-hospital GCS, what does it mean? I think it is just like a lactate. Lactate doesn't tell you why you're sick, what's causing the sickness. It might mean that you're in shock and that you're sick. A low pre-hospital GCS may be very similar. It might not be able to differentiate TBI. In its worst case scenario, it only has a positive predictive value of 60% in those. And this is in patients that are enrolled in hemorrhagic shock trials. I can't state any information regarding not. Acknowledgements, as I mentioned earlier, Dr. Frank Guyette is my wingman in anything clinical trial land. Multiple of my partners, research staff, and my chairman, Dr. Billier, and vice chair, Dr. Peitzman. And I'm happy to answer any questions.
Excellent, amazing presentation. And tell Frank I said hi. We trained together back in 99 to 02 in Pittsburgh, and he's just a great human being.
Cool.
This is a great presentation. The question I have for you, you harmonize the data from these 3 clinical trials, and I wonder if the different interventions across the 3 trials impacted the ability to compare the results. Because I know that you're giving plasma, etc. How do you comment to that question?
Because we were looking at, so plasma changed mortality. It changed it early, but it didn't change those patients that got a head CT, and it didn't change the pre-hospital GCS. And so we were intervention free on this.
Okay.
Now the interventions were pre-hospital TXA, double blind. It was unblinded but randomized, cluster randomized by plasma, and those 500 patients, and it was cluster randomized for whole blood in 86 patients in POWER. It was supposed to enroll 100 patients, but COVID messed it up. We enrolled 86. It was more of a feasibility type of study, but we still got good data, relatively granular pre-hospital data on that trial, so we included it. I don't believe didn't do the analysis, and since there was 3 different interventions across the studies, this was intervention naive, and it was unlikely to change the relationship between having an early CAT scan and documenting TBI. There are limitations, which we published in the manuscript. Some patients might not have got a CAT scan before they died. And it was some of those, whether they had TBI or not, may have been designated based upon the best evidence available. The vast majority of patients that died early had hemorrhagic shock, but they could have had concomitant TBI. So there are some limitations in this via secondary post hoc analysis.
That my follow up to that is, I know that none of these studies included whole blood. Many of us now are using whole blood, and it's we're not needing to intubate these patients anymore. Obviously, I'm talking about mainly hemorrhagic patients. Some of these patients do have concomitant TBI as well. But do you have an opinion on how whole blood could potentially impact not just GCS or just the patient's mental status, but also outcomes? I know I'm asking you to predict something that you didn't study, but just wanted to get
but a minor correction. The POWER trial was a whole blood pre-hospital intervention trial. So that was the first phase 2. That was the first pre-hospital trial. Pre-hospital whole blood was pre-hospital at that point in time at a couple centers across the country, but it hadn't been randomized. But I have seen patients with the shock burden and the injury severity burden. I mean, whole blood may assist your outcome. Plasma may assist your outcome. I don't know if it's changing your mental status en route or the need for intubation. And I think those may be disparate. I don't know whether whole blood versus red cell is going to alter whether you get intubated or not. I mean, don't get me wrong. I love whole blood. I'm not saying it's not cool, and I'm a fan.
Well, the New Orleans trial did show that. I mean, it was a smaller study, right? You had a couple hundred patients, but they actually showed that and I don't have the numbers in front of me, but it was something like only 2.5% of the patients got intubated versus a much higher number on those who didn't get pre-hospital whole blood. So, that I guess that remains to be seen potentially, but
I wasn't able to characterize that here. In non-randomized evidence, I haven't seen.
Right.
I mean, I haven't seen our pre-hospital providers. I have had some patients that on ground who have gotten some whole blood, which is starting up around our area also, that they were no longer eligible for our hemorrhagic shock trial. I have seen that. And so there's a lot of bang for your buck. So patients have gotten whole blood on a ground crew, and then our helicopter picked them up, and they were no longer eligible for our current definitive pre-hospital whole blood trial because they weren't, I've seen that. And you may be right that GCS may correspond with that hemodynamic change, that there might be some GCS benefits. That would be, interesting. And we might be able to find that out. Tower is enrolled 760 patients out of 1,000, which is a pre-hospital whole blood versus standard care. Swift is coming out of Europe, and I believe they might have hit their target, but I don't know when that trial. But European patients are weird. I don't trust their outcome data for the refill trial. I don't trust.
No. Yeah.
Why would you ever want to not give blood products early if you give them in your bay? If you give them in the trauma bay or in the OR, why would you not want to give them early? That makes absolutely no sense to me. That wouldn't make a sense to anybody. But the early bird gives the worm. That's like a slideshow that a slide that I have on every one of my talks, like intervening early, just like stroke, just like MI. Trauma is no different.
Yep. I'm going to bring in Dr. Pepe. I know he's got to go to his webinar here in a minute, but Dr. Pepe, go ahead, make a comment, please.
30 seconds. I think maybe this goes beyond the 30 seconds I have, but what I wanted to find out, I was trying to make sure I understood a little bit your remark, Jason. By the way, great job on this, and also more importantly for the plasma study originally. But if I feel that the plasma is useful in terms of helping to, stop the bleeding. So if we take Marty Schreiber's study, the TXA, where we found people who had intracranial bleeds and documented it later, and it helped out with outcomes there. I was just wondering if you had some before and after information on the. I would suspect that the GCS doesn't change that much, but do you keep it from progressively getting worse? And did you do any sequential GCS patterns? And maybe I just didn't follow that.
Well, we didn't. So the study that I presented was a single pre-hospital GCS that we had available that was in the data for all 3 patients. There is an ongoing trial in TBI patients, early plasma.
Yeah.
That is started. It's been through EFIC, and I worry that doing it in the ED is too late. Based upon PAMPer data.
Absolutely.
Those patients had shock, so you got to do it early. Now, freeze-dried plasma has just been approved in the U.S. for the Army, for the military, but similar to cold stored platelets about 6 years ago, it was also approved. So freeze-dried plasma is getting close. We're going to have it for civilian population soon, and that is a game changer. Regarding plasma, at least it has a long shelf life. You can put it in your backpack, put it in your lunchbox, put it by every AICD and stop the bleed kit, and keep it around and give it to patients with any kind of TBI and give it early. And it's a great resuscitation. You don't need to refrigerate it. And that's I think that's the next thing on the pre-hospital horizon once it gets FDA approved.
That's the blow dry approach as opposed to freeze. That's
exactly. But to your question, I don't have serial. That's an interesting question. So we have a trial this will, I don't have it as a definitive outcome for the Tower trial, which is pre-hospital whole blood. But if I can show that the GCS arrival was better in the whole blood, I will.
Or not getting worse. But that's the other thing, because
a delta. Yeah, if I have a delta GCS, that makes a lot of sense. I
got to go on another thing, but I was going to say I don't think you may improve the CAT. If you do have a bleed in there going on, you just want to halt it, and so it may still have the same impact GCS wise, but the others might be getting worse. That's all. So that's what I was getting at. All right.
Exactly. So you would look at a delta. So you would look at the delta, the change from pre-hospital to arrival, and see if it improves or not. That's a cool. I don't think it's listed as outcomes, but I might even consider changing that as a late addition to the protocol.
Okay.
Great comment, Paul. Thank you. I know you got to run.
Yeah, do give my best to Frank, by the way. I saw him a couple of weeks ago. We were talking about you. He was saying really nice things about you, so I straightened him out. Okay.
Okay, no worries. Okay.
All right. Awesome, Paul. Okay, we'll see you on the other side in a minute, but I want to move now to my co-host, my other co-host, Tanner Tamita. So Tanner, go ahead and make any comments for Dr. Sperry.
Yeah, so I had 2 brief comments and then 2 questions for you. So first of all, I think as a general comment, TBI drives a large proportion of trauma mortality in the United States. We've recently done a couple studies at our institution looking back at our registry data and down at West Virginia University, so a little south of you guys in Pittsburgh. And something like 90% of the patients who have died over the last 10 years had a severe head injury at the time of their death in the hospital. And so, moving forward, I think from a public health perspective, it's really important to try to improve the outcomes of this patient population, right? These patients with traumatic brain injury. But to do that, we need trials of interventions, right? And so, in order to demonstrate a benefit with trials, you need to pick the right population, right? So you need to enroll patients who actually have brain injury and not just patients that have a GCS of 3 because, alcohol intoxication or whatever else. You also need to pick patients who don't have irreversible injury, and then patients that have clinically significant injury such that an intervention can have a benefit, right? And so I think that this is such an excellent paper because it adds to the body of literature on kind of pre-hospital predictors of TBI and how we can enroll the right patients in future trials. So that was my first comment. Also, I think the population you looked at for patients who had hemorrhagic shock and also TBI is really interesting for a number of reasons, including clinical decision making. So one kind of question that I've heard a lot about these polytrauma patients is in relation not to just who would benefit from plasma, but other things like blood pressure targets, right? So we have data that pre-hospital maybe higher blood pressure targets benefit traumatic brain injury patients, and then conflicting data saying that, if you have a patient who's hemorrhaging, right, actively bleeding, maybe we should be, employing hypotensive resuscitation or fluid restriction, whatever you want to call it. And so I think, identifying which patients could benefit from different blood pressure targets is also kind of an interesting future direction and would be relevant for this patient population. So then my two questions. So the first one's related to your definition of TBI for this study. So I've been reading recently about like the modified brain injury guidelines. And I know enrollment criteria for those studies were like, you have to have a skull fracture or some form of intracranial hemorrhage. In this study, I believed it was defined as TBI, just kind of as adjudicated by a radiologist. So I was just wondering if you had any objective criteria for what TBI was. And then my second question, in case you want to comment on it, in terms of components of the Glasgow Coma score. So there's been some papers by Doug Kupis and others. I don't know if he's on today. I don't believe so. That just using the motor component of the GCS predicts outcomes equivalently to using the entire GCS score with greater inter-rater reliability.
Excellent questions. And so it got brought up regarding when doing this paper, should we just do it to motor? But I mean, then we would have had to argue. Then someone would have asked, why didn't you look at the whole GCS? Maybe, you know what I mean? Like, so we started GCS and I was already cutting the data so much, we didn't cut it, then just did a motor, you know what I mean? Like either or. So, but exactly. And then, I mean, I agree with you. The motor predicts. And I think we have another study that motor is like the biggest predictor of a mortality, is a single independent predictor of like mortality in a large, like 67,000 patients from the LIGHTS network, which we have. And that manuscript is in submission process, using the motor over the total score. I agree that I had a thought in your first question. What was your first question?
The definition of TBI.
So the definition was yes, the CT scan. This is from multi-center trials, right? So the radiologist had to say there's traumatic brain injury, there's a contusion, there's a it didn't just have to say traumatic brain injury, but it had to say neurosurgeon had to say this is traumatic brain injury in a sense, not neurosurgery, but radiology. But it wasn't there may be TBI. There's TBI. That was the definition that we gave coordinators to document that in their data set for these trials. Okay. There is a loophole, a little bit of loophole of those patients that didn't survive to the CAT scanner. And then that was adjudicated. If there was like an axe sticking out of the brain, they've said there was traumatic brain injury. And if they pretty much exsanguinated out of the bottom of, from their traumatically amputated thigh, and they might have called it hemorrhagic shock. And so, you know what I mean? Like when we adjudicated at the site level, was there TBI in the sense in that small patient population? And does that answer your question?
Absolutely. Yeah. Thank you very much.
And actually, Jason, Doug Kupis just joined. So Doug, Dr. Sperry just answered a question that Tanner asked about using the motor aspect of the GCS, and he agrees. Did you want to comment on the paper you wrote? I actually put your paper in the chat, Doug Kupis.
This is sort of like jump right into the fire in the middle of the conversation, and I apologize for that. Peter's like, well, we're just getting to that. You can join right now. Yeah, so, the paper that we did was a very large population of patients looking at trauma and looking at the performance of the GCS versus using the total GCS of 13 or less versus looking at just the motor component, which is so much easier to teach to people because for the purpose of trauma, we split it to, do you have a perfect motor GCS? In other words, can you follow commands or not? And if you can follow commands, It is essentially as predictive of calculating the whole GCS, which is frequently done incorrectly or guessed at by people. You know, the number of times on a medical command call I hear somebody say, oh, their GCS is about 10. Well, what does about 10 mean? You know, that means you're just guessing and eyeballing the patient. So the follow commands versus doesn't follow commands is very valuable because it performs almost identically to a GCS of 13 or less for need of neurosurgical intervention, significant traumatic head injury, bleed, etc. Ours is not the only paper that showed that. There were a couple others. Teichmann, the trauma surgeon at UPMC, showed it several years before us in a different patient population. And it takes out the complexities of teaching and expecting somebody to do a GCS calculation on the fly with a critical patient. And it simplifies who is really going to benefit by the trauma center. So that and about 3 or 4 other things are what helped the ACS COT change the guidelines for field triage of trauma patients to trauma centers in 2021 and remove total GCS and put in GCS motor does not follow commands. And I think, you know, we've done a little bit more work just recently with that, with an ESO project that shows there's probably that's probably valuable in a lot of other things, like identifying patients that are at higher risk of mortality that you're bringing to a hospital. You know, maybe we don't want to look at this in just trauma triage. Maybe we should use this as another part of what's called the RPM score, which is the patient's pulse, respirations, and the GCS motor. Looking at that, that combined composite score actually identifies mortality in both trauma and non-trauma patients. So, you know, there's probably a simple score that could identify to a hospital, hey, we're coming in with a patient of this score, and they've got a higher chance of death than other patients. They've got a higher chance of morbidity, et cetera. So hopefully that's a helpful description. I hope I wasn't repeating some of what you'd already been talking about.
No, I think we have some data that might be coming out relatively soon, the importance of GCS motor also. We didn't do it for this paper though. And I had tortured the data enough. Actually, I didn't want to torture it anymore.
Excellent. Excellent. Well, Dr. Sperry, this was amazing. I know I learned a lot, and just want to thank you for all the contributions you have made. I mean, we're all mainly, most of us, I would say, on this call are all EMS folks. And obviously, it's quite hard to do these big RCTs. You know, people want the big RCT on whole blood. And the question is, you know, is that ever going to happen type of thing? But this is definitely helpful. So I'll give you the last word. What would you tell us, EMS folks? Any last words before we end the session today?
The early bird gets the worm.
You know what? We love that. Yeah.
I got that on every slideshow I gave. I mean, it's true. It's like, but that's with any problem pre-hospitals, stroke, everything, and it just makes sense. And so,
well, to hear a surgeon say that, it's music to our ears, because it's interesting how sometimes some of the surgeons, they fought us like hell, man, down here in South Florida, and now they're all on board. But it was a little bit of a fight. So I'm glad that you're saying that, and we really appreciate your time today. And thanks for everything.
No worries. The pre-hospital arena is where the warriors live, man. I can't say that enough. So,
well, thank you so much, and to all the people who do the real hard work in the field, we owe them a big debt of gratitude. So, thanks for all your work. I hope to meet you in person one day and say hi to Frank.
That's cool. Thanks, guys.
Awesome.
Enjoy.
And thank you, guys. And then for everyone else, stay on. I'm going to put the Eagles link here in about 10 seconds. Just a reminder, and I know Joseph, maybe I'll have Joseph Zalkin just come on and say, Joseph, you want to give everyone an update on the national meeting coming up in January? Anything you want to say? I told everyone about our Florida dinner on January 10th at 7 p.m. Do you have any other comments before we depart?
Registration is open, and if you are looking for committee or chapter dates and times, they are going to be released no later than midweek next week, along with the completed schedule. So I would encourage you to come. It looks like a great educational program.
Great, and it's going to be a great Brazilian dinner on. And Tanner, you're invited. Tanner, hope you can come. And of course, everyone from Florida is invited. And if we have room, I think we have up to 50 people. Others are invited. So fill out the link that I sent you guys. Thank you all so much. Appreciate you, Tanner, for everything. You're amazing. And then you can click the link, and we'll see you on the other side of Dr. Tepe's webinar. Have a great weekend. Stay safe. Stay dry. We'll see you guys next week for another great webinar. Have a good one.
Thanks, everyone.